We're going to talk about ethics in implementation. So there's a distinctive here that I need to make straight away. Ethics in implementation is the thinking about and the process of organizing and managing to do implementation in a way that is ethically apt or appropriate, conducive to good ethical practice. And I did some review work with colleagues from Adelaide, Australia, and you can see the list here. This work was conducted mainly by my colleagues Matthew Leach, Vanessa Boccazani, and Alexa MacArthur, Lucy Lynn Lizarondo. These were all my research team in Adelaide. And from Portugal, we have Daniela Cardoso, we had Fraser Underwood from the UK, Laura Albanos from Spain, Mariana Zazou from Romania, Hannah Kim from the USA, and Rogerio Rodriguez is a very handsome Portuguese man. So that was the team that was involved in this work. And here's where we're going to go in this talk this morning. For the background session, we're really going to focus on a couple of core domains. One is to think about what I call moral halo. Does everybody know what a halo is? What's a halo? Can somebody, like if you've seen pictures of angels at Christmas, do they have a halo above their head? So a halo represents something, doesn't it? What does a halo represent? Goodness? Can we say a halo is a metaphor for goodness? Like, do a bad person ever have a halo? No, never, right? So good people, halo. Nurses, halo. Yeah, all nurses have a halo, right? Because we all do good things. So we're going to talk about this construct of the moral halo a little bit. And then I want to tell you about the research that we did and what we found and what it means for thinking about implementation work. And maybe you feel like you've never done implementation work, but I'm going to show you that if you've been involved with quality improvement or safety and quality, you've also been involved in implementation work. All right, so here's where we're going. I'll start my timer so that I don't go over time. But I think there's a few interesting points to observe about the nature of nursing and nursing practice in relation to ethics. Nurses generally have a low awareness of ethics in our day-to-day practice. Is that a controversial statement to make? It is a little bit, isn't it? But what do I mean by this? So when we think about what we do as nurses, it is good, right? It's good. So we believe and act in a way that is congruent with legislative frameworks, with codes of practice, codes of conduct. All of this guides at a high level the structure, functions, and processes of nursing. But I would also argue we don't really think about ethics. We do nursing within a framework that supports ethics, but that's not the same as having a high awareness of ethics. And when you think about our education and training, we get courses on ethics, and they often deal with very extreme outlier scenarios. So if somebody doesn't get appropriate pain relief medication, that's unethical. And that's an example you might hear in class, for example. The vulnerability of minority and ethnic groups, there's a lot of ethical issues that we often unpack. But in our day-to-day practice, if I'm really busy and I know that I've got 10 patients to care for, I have to do all their vital signs for the morning round, I have to give them all a wash, attend their hygiene and skin needs, I don't really think about ethics. Why? Because I'm doing good. It's implicit. And I actually want to challenge the assumption that ethics is implicit with doing good. I think doing good is the moral halo effect. So not always truly that thing. So we have a low role function in relation to ethics as well. I would bet no one online in this meeting today and no one in this room has ever needed to challenge another nurse's practice on the grounds of ethics. None of us would have, I'd imagine. So what do we do that is routine to nursing and relates to ethics? Well, actually, the most common things that nurses do is we check other people's ethics, right? Preoperatively, we go through all the paperwork. We check, did the patient sign a consent form? Blood transfusions, other things that require patient consent. We're big on patient consent. We really check. That is, we follow the patient journey. So really we gatekeep other people's ethics more than we think about our own. And it's interesting to even say it out loud, but I think the main role for nursing is that we check that other people have done their due diligence in relation to ethics. Fascinating way to start the day, isn't it? Thinking about ethics in a different view. So, and part of the reason we do this is because we want to care for and protect patients. And another part of the reason we don't routinely think about ethics so much is because we're doing good. There is a general belief in nursing, and I don't challenge the belief. Okay, I accept the belief. There is a general belief in nursing that we're doing something good and positive. But I think there's a question here. Is doing something good and positive, or believing that it's good and positive, is that the same as being ethical? What do we think? Is it the same, or is it sometimes different, maybe? You think it might be different at times? Professor Patraporn says all three. It can be the same. It can be a little bit different. It could be very different. Yep. Good academic answer. Academics always have the right answer, don't they? Yeah. But this is what I want to talk about with you for a little bit as we start to get into our talk together today. So here's where we are. Nursing, or if you like, nursing practice, is inherently ethical. Are we comfortable with that statement? Nursing practice is inherently ethical. And this is a very common belief across nursing, everywhere in the world I go. This is very common kind of conceptualization. And it's very understandable because when we think about what nurses do and why and how they do things, it's orientated toward care for others, right? Care for others is core to what nursing is and how it works. So we do things like we relieve suffering. If somebody can't attend to their daily fundamental needs, we help them with that. Nurses are amazing people. Our goal is to assist people to either a good life or sometimes to a good death. But in all cases, we're seeking to assist human flourishing. That's our core goal. Can we help people to flourish, to experience wellness in some way that might not be able to do without some assistance and help? And historically, nursing has come from being what was perceived as a moral vocation. So if you go back far enough in time, hundreds of years before Patraporn was even born, nursing Western nursing in particular was religious. It was an act of service to a higher being by expressing care, love, devotion, and attention to humans created in the image of a higher being. I don't actually know the history of nursing here in Thailand and if there are similar roots, but I wouldn't be surprised if there's a strong correlation between religious belief and the early formative stages of nursing in Thailand. Somebody should look it up one day. So historically, it's been an act of service, not an act of duty, a moral vocation. And some of the consequences of this are really interesting. So don't quote me on this outside this room, right? So this is just for us. But in Australia, nursing, there's two professions that are always rated highly for trust. Nursing is one. Can anybody guess another one that's based on service to community? Have a guess. Come on, be brave.
Speak up.
So there's one profession in addition to nursing that is highly trusted in Australian society. No.
Doctor?
Teachers.
Same as Japan people.
Yeah. So one of the benefits of being a nurse is that you have a high status position in terms of trust.
Yeah, nursing instructor.
Yeah, so your double benefit, nurse plus teacher, is win-win, right? It's the best. You know, so you don't make a lot of money, but you have high social value in everything you do as a nurse. Guess where politicians sit? High in Australia. High or low?
No.
Low trust, right? And maybe there's historic reasons that these are seen as really different. But nursing is seen as morally a positive kind of profession to be involved in. And one of the things that I think comes from this is we take the view that because the role of a nurse is a good role, it is benevolent, it is acts of service to vulnerable people based on a high degree of knowledge, skill, qualification, expertise. A nurse is a remarkable person. And sometimes, though, I think we make this assumption that because the role is good, we assume the actions are good. We assume, right? I'm a nurse, I go to work to do good. No one's ever said, I'm a nurse, I go to work to do a bad job. Like this never happens. Even if I'm not a very good nurse, I still have good intent. And I make an assumption that my intent is an outcome. So because the role is good, we assume that the actions are good. I want to challenge that a little bit because I don't think it's explicitly true. So this is perhaps a little bit controversial, but see what you think. And I think it's not necessarily true, mainly in relation to implementation. Okay, so I've been talking about moral halo, about role being good, therefore I assume the actions and activities are good. And you've been thinking about practice. I want us to move our mindset now and for a few minutes focus on implementation and think about changes we make to practice. Implementation or quality improvement, EBP, evidence-based practice, same, right? So we want to make changes to practice based on good evidence, We want to measure that to determine that it's worked well. A very common mechanism of action is audit and feedback. And you may not know it, but I'm sure you've been audited. And you may have even been involved in a change project where you were collecting data and observing what was occurring, taking notes, and then evaluating that data as well. So implementation has a lot in parallel with quality improvement to drive the quality of care up, improve patient safety, just using a slightly different framework because it's evidence-based framework. And one of the questions is to think about nurses in a similar way that we think about patients. So if a patient chose to opt out of a research project or out of an intervention, we would stop the intervention. How do nurses feel about being involved in quality improvement when the nurse is the subject, right? So that's what this little study was looking at. And so where it comes from is thinking about implementation studies that seek to target the behavior, or if you like, the practices of clinicians. This has been studied in bioethics. And there's a complexity of balancing issues here. So is there a real risk? What is the nature of that risk and the degree of risk to health professionals who are going to be audited versus the degree of protection that they should be afforded from those risks? So we know that patients can opt out through informed consent, whether it's from a research program or from an intervention that they change their mind about. What about for clinicians involved in auditing or even accreditation, to be really controversial? Could a clinician choose to opt out? And what would it mean for that? So there's a lot of questions about whether if I'm doing implementation and I go to your ward, do you have a choice or no choice in that matter? So that's an interesting ethical perspective. So it's just one part of what we're going to look at together today. Is there an obligation on you to participate, or is the inability to opt out some kind of violation of your rights and your professional conduct? So this has been studied, and clinicians were asked how they felt about the ethics of their involvement in implementation. And the answers are a lot like Professor Patriborn's answer. It was multi-layered, which is not surprising because it's a complicated issue. So of course it's multi-layered. And they were thinking like, well, it depends on who's at the bedside. Who are you observing? Is it me and I'm an expert? Or is it one of my colleagues who's very junior and they would feel a lot of pressure and maybe not cope so well with being observed in a knowing way? So what are you really studying is one question. And the second point here is, well, you're not really studying me, you're studying the nursing process, what I do, not me personally, who I am, but what I'm doing. So you're looking at the technical skill or compliance with the best practice guidelines. You're not really looking at me. So I'm happy, I'm comfortable. You're looking at a process. You could give me feedback and it might improve my process. So for me, that's a gain. And then other people were like, well, what is it? That's a good question. I don't really know. We're always trying to make improvements anyway. And so maybe it's a good thing, not very sure. So nurses have this layered approach. And I found this quote. So this was a qualitative quote from a participant. I think they're the recipients of the better care, Hopefully. And I kind of believe that. I know there's always unintended consequences. And how can I say it? I don't feel like some kind of moral obligation to involve them. So this person feels like you might not need to worry about consent for health professionals. And health professionals are busy doing a good role. So maybe it's not important to consider uh, their actions. Why? Because they talk about people being recipients of better care. And I think this is an example of a moral halo. So I don't feel some kind of moral obligation to involve them. And they're talking about consent for involvement in quality improvement or implementation work. But you don't need to, because they're already trying to do good. Not that we've measured and evaluated and found the good, but they're already trying to do good. Other impacts that might really affect people are to think about reputation. Not to say I don't worry about my reputation, but this could make me a better clinician and then improve my reputation. So I have no problem. In other words, observe me, watch me, measure me. I'm going to embrace this as an opportunity to refine, to learn and develop professionally. But also some nurses think about, well, if you do an audit, what if the results aren't very good? So we have this complex, multi-layered perspective. Professional challenge, professional growth, but nurses work more in teams within organizations, right? We have a team-based culture in nursing, and we work for an organization. We don't work for ourselves. So some nurses would be concerned about reputational damage to their place of employment. And that's actually worth thinking about and considering. I'm in favor of transparency. I think transparency is best, but that doesn't mean there couldn't be unintended consequences from transparency. So the third person goes, no informed consent was ever obtained by me to meeting the standard of care. We'll have people auditing us, watching us, evaluating us to make sure we meet the standard. And that's no different to our expectation. So being audited is like the normal process of care. And there should be no aberrations that make it overly complicated for involvement there. So I've mentioned unintended consequences a little bit already, and I just want to think about that a little bit more. These are the foundational ethical principles that inform sort of like the jurisprudence, the frameworks and governance that nursing is structured upon. Autonomy, benefits, non-malfeasance, and justice. And those are very traditionally linked to research grant applications. And this is a problem in that institutional review boards the world over, they understand the research domain, but they don't really understand the implementation domain and how that actually differs in substantive ways from the traditional high-risk human research grants they receive. And so they don't have any clear guidance on how to evaluate the ethical integrity of implementation studies. So what do? They apply their traditional research framework. But these are not the same pieces of work. They're really different, right? Not that one can be unethical and one ethical. I'm not saying that at all. But what I'm saying is IRB groups have real trouble trying to frame and balance the differentiation. And there's no useful guidance worldwide, really, on how to deal with these important differences. So when his IRBs are a problem, thinking about personal professional reputation is a little bit of a problem, a little bit of an ethical challenge. And in terms of unintended consequences, if we're always innovating, if we're always improving, if we're always adapting, what are we really doing to our nurses? We're adding strain to their work. Nurses in Taiwan work very hard. I've just been there for a week, and the pressure on their health system is quite significant right now. But it's the same here. You have a lot of pressure on yourselves as academics and as senior clinical leaders. And it's okay for me to say that and to admit that. So there's a lot of additional strain that comes with this constant drive to improve, right? There's our baseline level of care that we provide is up here already. It's high. And then people say, now I want you to do this work and this work and this work. So unintended consequences can include fatigue, can include moral fatigue, can include emotional fatigue, as well as physical fatigue. And that's not the intention, that's not the goal, but this is part of the unintended consequences of thinking through implementation and how it might work. And one of the problems that causes that level of fatigue and that strain on individuals is what I call structural inefficiencies as an unintended causative agent. So a structural inefficiency is where somebody sells or somebody convinces you to be involved in implementation work where it's all your energy, where the system around you is not appropriately supportive of that work, right? It is a structural inefficiency if doing implementation, QI, or EBP is just relying on you as an individual, your leadership. And I believe we do this to nurses all the time. And to be really clear, I believe that is wrong. That is the wrong approach. We are not looking after our profession well enough if we don't make implementation EBP structural so that there's shared leadership responsibility, shared infrastructure and governance to distribute the burden. So if we're relying on a system, on an individual, that is not systems integration. That is relying on you to be the hero. And you should not need to be the hero, right? Ignoring structural issues is like this Japanese art form that you might have seen. It's where they take a piece of broken pottery and put it back together perfectly imperfect by using melted gold to put the bits back together. And it repairs the cracks. The crack is repaired. The bowl is now functional. And it looks, well, it looks beautiful, doesn't it? Do you think? I would be honored to own a bowl like this. It looks beautiful. But actually, this is nursing as well. So it looks pretty, but it's on the individual artisan entirely. And this, in the same way, focusing only on the clinician and for them to carry the burden rather than for us as an organization or as a national body of nurses in Thailand to deal with the structural inefficiencies, that leads to this every time. And you can only repair so often, right? So we need better structurally led leadership. All right, that's the first half hour of this talk. And I guess what I hope you got from it, sorry, I wonder if I can go back. Yeah, I can. There's a lot of interesting ethical things to think about. And they relate mainly to, we make assumptions about nursing in implementation and QI. And I want us to sort of peel back the layers and stop making quite so many assumptions and instead consider the ethical issues. Part of my role is as editor of an implementation journal. Not once have I received a paper that described clearly the ethical steps that were used to do implementation. I've read hundreds and hundreds of implementation papers. I've never had one submitted that said anything more than this paper was reviewed and approved by IRB board number XYZ7398. From an ethical point of view, that tells me zero information. And if you were a nurse in America reading about this innovative implementation work from Thailand, but you saw no reference to ethics, you have no idea about the moral safety for the nurse, the moral safety for the system, or the moral safety for the patient, right? So I think that's my real underlying driver here is there's a complete absence of good guidance for who makes that decision to waive ethics. This is QI, we don't need ethics. Fine, but who's that person and are they the right person to make that conclusion? You got to remember, a nurse in Poland or Vienna does not know you. So when you write, this project did not need ethics approval because it was considered QI, who made that decision? On what basis? And even if that decision's okay, what steps did you take that were ethical? Because not needing IRB is not the same as not needing to be ethical, is it? We always want to be ethical, but if we assume our moral halo, ethics falls over immediately, right? Because we can coerce and convince people with the strength of our halo, but that's not professional. We actually should convince people on the strength of the work that we want to do. And our work should be ethical in implementation, just as it should be ethical in all other aspects of our practice. All right, so let's push through. Now, what we did in recognition of this kind of challenge to think about if there's a lack of existing guidance and guidelines, how do we move forward through that to try and reach the point where we've got something useful to offer the world? So my team and I did this research looking, and this is what I really wanted to share with you for the next 30 minutes. So we looked at trying to situate, and a lot of people will disagree with me, but for convenience, I'm going to say this is the case. EBP and QI and implementation are the same. There are differences, but for the purposes of this talk, they're all the same. They're all about changing practice to meet a standard. EBP, the standard is external international evidence that's been subject to peer review, et cetera, et cetera. QI, still about a standard, isn't it? So same. And we want all of this to be patient-centered in order to address some aspect of the nature and quality of care, whether it's an inefficiency, whether it's unexplained variation. And you could do a whole lecture series on unexplained variation in nursing practice. It could be suboptimal performance as defined by someone. So in my healthcare system in Australia, the sepsis rate in my city on average is about 1.3% of critical care high dependency patients. It's pretty low, right? But my government is unhappy with that because morbidity and mortality is very high. So performance could be good, but maybe there's a number of factors that influence or define what is suboptimal. You know, we tolerate more illness in adults than we do in neonates and pediatrics, for example. And we will spend millions of dollars to preserve one premature baby. So we have these nuanced ethical perspectives. But here in implementation, I think is where EBP has engaged fairly deeply with the QI movement and started to merge more substantively together. And we have groups that do this professionally and want, so to really drive and be a part of this global collaborative process at improving the use of evidence in clinical decision making by nurses and other health professionals as well. And JBIC is really passionate about this. Our whole mission is really about this piece, I believe. We do lots of systematic reviews, but implementation is where that becomes meaningful, becomes actioned. Yeah. So we're giving increasing attention to rigor and quality, asking questions about, reliability or validity or transparency or reproducibility. And all of these are research language words, aren't they? You know these because you guys are all expert in research. And there's bound to be a lot of other really important questions as well. This is not a comprehensive cover all the kinds of issues that we need to talk about. But as I was saying before, there's a notable area of concern for me personally, and I think for the profession more broadly, and there's a lot of debate around it, and that is around the ethical integrity of QI projects. There's no clarity, to be honest. There's no clarity. There's high ambiguity. What are the ethical requirements for QI? And to what extent do they need ethics review and oversight? And that was a driving question for us, because after reading hundreds of these papers, publishing most of them, I started to question who's making the decision and why? And are they the right person to make that decision? How would I know since I'm not there? And even if there is an exemption granted, shouldn't there be a process that's clear that I could understand and read about in their work? And there really wasn't. So maybe this relates to the moral halo effect as well. QI doesn't really need so much oversight because it's inherently good. But everything has unintended consequence. So even something good can have unintended consequences. So whether or not QI is, can, or should be treated like research, people debate that all the time. And just to be honest, I'm not into that debate. It doesn't interest me. What does interest me is trying to unpack the halo effect because of these reasons on screen. QI activities do include risks. Implementation and BEBP activities do include risks. QI activities may cause harm. QI activities may, in fact, do increase burden and cost on people and organization. And in a world that doesn't want to pay nurses what they are worth, QI activities can waste scarce resources. So what am I measuring and why? Is that strategic? Is it aligned with my organization's priorities? Does it fit an appropriate national framework of key areas of nursing focus? In other words, am I doing work that contributes up and down a chain? Or am I just doing, do you know the term siloed? A silo? In Australia, a silo is a large cement container to store farm produce, and it doesn't connect. It's sealed. So we don't want to be siloed in our work, right? If you, yeah, you know this, so I won't. So we want to not waste scarce resources. We want to maximize, and not just with dissemination, not just share my paper, right? But active transfer and helping other people learn from what we learned. So avoiding that. Here's an example, though, of an unintended adverse event consequence. This is from the UK. what they were finding is people who were admitted to hospital on a weekend were much more likely to suffer morbidity, mortality in hospital than people who were admitted Monday to Friday. So they implemented a new QI initiative in order to decrease the risk. And it was really a rapid assessment process. So people come in on weekends, we will do an integrated rapid assessment so we can identify risks before they turn into problems. And that will reduce morbidity and mortality for people who are admitted on weekends. They measured 14 million data points. Huge data set, right? Massive. And the QI initiative led to an increase in mortality, not a decrease. Unintended consequences. So we have to take unintended consequences reasonably seriously, even if our scope and framework of thinking is quality improvement implementation EBP. We can't assume a moral halo. So what we did was we wanted to develop guidance that would be relevant internationally to operationalize assessment of ethical integrity for QI and evaluation activities. We had 4 objectives. We wanted to develop preliminary set of ethical criteria, map them against all existing guidelines that we could find, and then create a modified version of an instrument that would balance the evidence against other international standards and evaluate it. So 4 simple steps. We did a rapid review. We found 209 different documents around this, and almost none of them fit implementation evaluation work. But there was one from the Australian National Health Medical Research Council on evaluation as an activity. And there was another from the UK Healthcare Quality Improvement System. And so we analysed these 2 working documents, extracted 23 core items that relate to ethical integrity for QI. And on analysis, we took those 23, we broke them down, and we developed, in the end, 5 criteria that would help define what level of ethical review, right? So sometimes in the paper, the lead author says this project did not require ethical review, but they might just be one person, or they might state the director of nursing, the senior director of nursing, or the executive director of nursing. So that's like a person level, but then there's different levels of committee ranking as well. So then we looked at and we identified an additional 4 criteria. What would be a reasonable basis for exemption from ethics review? Reasonable basis that I can then articulate in my paper. And are there specific triggers that should require ethics review? And if either case is true, so either I do not need ethics, I can proceed. I do not need IRB, sorry, I can proceed. Or I do need IRB, I get IRB and I can proceed. In either way, what are the fundamental ethical principles that should guide my implementation work, my QI work? We had 7 criteria that we came up with. So I'm just going through the methods fairly quickly for you because I tend to talk too much. I do at times. Yeah. So we used these 23 criteria and we systematically mapped them against all other identifiable IRB documents and policy documents using a rapid review to try and identify them. And then we went from there into a process of, cross comparison between documents and used the e-Delphi technique, where we took those 23 preliminary criteria out to a Delphi group and consolidated them into 18 defined statements. That was phase 3. The e-Delphi was a little bit like this, like every other Delphi study you've ever read. We asked people to rank each of the statements, and we had an open-ended section where they could provide comment or feedback on them. and we used a panel of implementation science experts. In that eDelphi, we then invited the same people to co-participate in phase 4 of the study, which was to evaluate utility and reliability against a set of randomly selected publications on QI activities. So we developed this instrument through a rapid review eDelphi process, and then we pilot tested that against a broad range of randomly selected literature. So that was our program in a nutshell. And kind of here's what we found. We identified in total 688 records, of which 18 were a good fit with our proposal, and they came from different countries. So we had really good cross-cultural representation. You're not expected to read all of this, but suffice to say, very few documents, and you can tell from the lack of tick in those boxes. So very few documents really covered substantively what we had identified as the core needs for ethics in relation to implementation. So there's a lot of gaps that we identified in existing guidance and documents around ethics approval and ethical practice from every country that we looked at. What do we got here? We've got the UK and the USA and New Zealand probably had the most reliable guidance in terms of comprehensive coverage, but no one had complete coverage of any of all the domains. So then that was really fascinating, and it sort of proved our theory that we just don't have enough good guidance. So then we developed this instrument within phase 3. And remember, phase 3 was that Delphi consolidation process. And then phase 4, we did a pilot evaluation of it. So in phase 3, we came up with, if you're reading a paper, what should you be able to see in that paper? Did this project, and by project, we meant QI implementation EBP, okay, just to rephrase that. Did this project undergo ethics review? Well, it could be not applicable if it's a protocol for a project. It could be no, the project did not go under ethical review, defined as IRB. Yes, the project was reviewed by QI or low risk. So you know how I mentioned level before? Full IRB, high risk, human or vulnerable group. Low risk IRB is a layer down, I guess down. It's probably a continuum, really. The project was reviewed by the chair or an appropriate committee, so not a full committee. And again, it's a slightly different layer of ethics review, different level. Yes, the project was reviewed by an appropriate committee or an individual responsible for clinical governance. So this is when it doesn't go to IRB at all, but it might go to a clinical, safety and quality department or some group like that who have oversight. And maybe there was a different pathway. Some hospitals do local clinical ethics review, and they have. You guys already know this. I didn't. I thought that was a really rare thing to know, but everyone's nodding. It's a pain point. Well, let's talk about it over lunch. I want to learn more about that because I'm fascinated by the notion that ethics review can be peer driven. I think it's a really clever concept, but I'd like to learn more about it. It was there in the literature, and it was definitely there in the Delphi study as well. And so then we asked, well, what would a reasonable basis for exemption look like? And so this came from the literature and it came from the Delphi, right? We didn't make this up. This is from the data. A reasonable basis for offering exemption. The data are routinely collected anyway, right? So routinely collected data. Primarily, that data is used to maintain standards or identify areas for improvement within the local setting. Project data are not linked to individuals, so we're protecting anonymity, confidentiality. And I would love to see those words used more in the publications I read on implementation, but it's very rare. Now, if 1 to 3 doesn't apply, then you tick the fourth box. None of the above statements apply to my project. If none of those statements apply, there is no reasonable basis to have exemption from some kind of ethics review. It doesn't have to be high risk human full IRB, but someone should be looking at and giving full consideration. And then we can evaluate which of the following statements apply to the project. Well, the findings could infringe privacy. This is a gray area, right? Because when someone's observing your practice, does that infringe your privacy? It could be yes, couldn't it? It really could be yes. Depends on what data, how it's collected, and then how it's published or used. The data is routine, so from QI or evaluation, but it's being repurposed to do something different. So we're now using data in a way that it was not intentioned. So that should require ethics review. Or the project gathers data that is non-routine, non-standard data. Now that might even include patient surveys. Or we're testing non-standard treatment protocols, equipment, and devices. So we've got a new wound care innovation, should require ethics review. Or we're using an experimental or quasi-experimental design. Or the project undertakes targeted analysis involving minorities and vulnerable groups. So those are reasonable cases for where ethics review should take place. And they are all reasons that could be documented in a publication as a really good justification for IRB. So not simply that statement, this project was approved by the IRB project ID number XYZ7389, but this project was approved by IRB, here's the project number, because this project involved the collection of data from minority and vulnerable groups. The rationale is everything. Do you agree? Annie, do you agree? Meng, do you agree? The rationale is everything, right? And if I can't articulate my rationale, what kind of scientist am I? Like, I need to be able to articulate my rationale. And if I don't, you should tell me off. Right? Tell me off. Cool, good. We're doing really well. Thank you, everyone. We're having a great morning. Whether or not we get ethics approval or need, based on analysis, ethics approval, my practice should be ethical. No room for moral halo, right? We're going to take the moral halo off, put it to the side, and make sure that we do and report ethically. That's our core goal now. And we're nearly at the end of the talk. So to what extent in my project have I and my team demonstrated the worth of the project? How many times have you been asked to do extra work and you know that work is low value, not high value? So where's the merit? Is it like we should be able to articulate this? We should be able to describe this. We should be able to defend this. So the project should be justifiable. And the people involved in the project should know what they're doing. Like, that's just common sense, isn't it? Integrity. The project uses sound research methods and will be well reported. I'm an editor. I would love to see more of this one, much more of this one. This would make me so happy on a spiritual level. Justice. There is fairness in participant selection. Not coercion, fairness in participant selection and recruitment and how we manage the program. Benefit, respect, risks. Why? Because there are potential unintended consequences to every action. And if I can articulate them, it means that I've thought it through. If I can't articulate them, it means I've not thought it through as an issue. And I should be responsible to think this through and to be able to say, look, the intended benefit is that we comply with best practice, we reduce costs, we save time, and patients get a better standard of care. But there are some unintended consequences that may occur. And then I should list those out. Like I should have thought that through. So benefits, respect, risk, consent. It's a tricky one. Like, should we be consenting nurses to be involved? Well, there should be a process. Like there should be a framework for within which those kinds of decisions get made. So ideally, yes, there is something there. So that is our four sort of framing domains in this new instrument that's been published. And I think before I finish my discussion conclusions, I want to say I hope that you, if you're thinking about implementation or QI, that you read it, that you use it, and that when you go to write your reports or your papers for submission, that you really use it, because it's the only instrument of its kind in the world that actually helps clarify what should I write? How should I write it? In order to prove that what we've done was something we thought about and operationalized well. Now, if we do those things, we are massively contributing to the improvement in quality of implementation science and to organizational and professional reputation. Like these are win-win scenarios for the whole of nursing, for every hospital and university that embraces and uses this framework. So we were honestly a little bit surprised by the lack of good guidance around ethics for implementation evaluation. We'd noticed it in our own papers that we received, but we were really surprised to find this gap was worldwide, literally worldwide. There was a lot of guidelines for activities that were treating QI the same as research, and were reliant on research ethics literacy among people doing QI. But this is not always true. You can be really good as a nurse at QI and have low research literacy. But if you have low research literacy, you've never learned ethics. So the tension is harder for you than as a nurse. So this document, these guidelines help improve ethics literacy specific to QI to relieve the burden, right? And this tool gives us a standardized, uniform means for a reader of your work. So they go, oh, that's a really interesting publication in PubMed. They see it, they download the paper, they're reading it, and they can see what were the ethical issues we considered? What level of review did we get? How did we guide our practice using an ethical framework in order to ensure that we protected patients and staff from unintended consequences? This is powerful, good practice. So that's that sort of thing. I've already just said this, I suppose. What we're trying to do is to avoid assumed research literacy, because assumed research literacy is unfair. We've avoided assumed ethics experience and expertise by making it utterly clear. And we've dealt with the current limited access of current ethical guidelines for EBP and QI activities and improved clarity for readers of published work who would otherwise have no clear idea about the ethics related to implementation and QI. What we're going to do next is develop and publish a reporting standard to guide the global literature and publishing houses worldwide. and then do further empirical testing of this work. So thank you very much. I hope that's been interesting and encouraging to think about. I will stop sharing my screen now, and I see we've got 2 comments. Oh, okay, those aren't questions for us. So over to you. Are there any? We still have a few minutes. Do you want to comment? Do you want to question?
Discussion.
Thank you for your useful presentations. But I would like to ask about which stage, if we would like to apply these 18 item tools into to access for QI project. Should we start at the beginning or during the implementation phase? Or if we get published, we need to accept and submit for review. So I'm just thinking about which process that useful for us as the researchers or QI investigators. Thank you.
Thank you. That's a great question. I think it begins with planning. So when I'm starting my project, the more I know, the more comprehensively my project holds together. So I would begin my project by talking through the topic with my colleagues, with my senior management, because I want whatever I do to add value, not just to my unit, my silo, right, but the whole organization. So I talk up and I talk to people in my area as well. And that's when I would start thinking about ethics and listen to, because some people will have concerns straight away. And that's a flag to think about ethics. And also in the planning phase, you're thinking about the topic, you're thinking about what are the data points, or sometimes who are the data points. And that's immediately an ethical question. Who are the data points? So it's helpful to start documenting this early on in project planning phase. Makes the write-up of a paper later much easier as well. Yeah. Really good question. You should get promotion and pay rise. Yeah.
For your application, that would be great.
Oh, core staff champion. Yeah. Thank you.
I'm Prathum Soiwong. I'm a faculty, and I have a question in terms of the implementation. In the period that we implement the guideline, we need to do the informed consent. And because when implement in the unit, every patient in the unit need to be in caring for the patient by using the guideline. And in ethical point, we say that they can freely to say no to join in the study. However, at that time, we need to implement in the whole setting. What is your suggestion in terms of if the patient say no? Because we need to implement in the unit, right? In the whole system. Yeah.
Such a hard question. But I like the question because this is indicative of the routine complexity that we grapple with as nurses all the time. And without knowing what is the exact thing where we have a policy that says this will be implemented system-wide, and that's reasonable. We have to have those policies or we have chaos, right? So the policy is good. We're going to implement this guideline and this will apply to all clinicians, sorry, to all patients. So are there pathways in the guideline for different patient needs and preferences? Because there should be, right? If you think about the average clinical practice guideline, it's based on the average patient, but a good clinical practice guideline will recognize that we don't treat all patients the same way because they have different comorbidities. They have different medical history. So a recommendation will apply perhaps to a majority of patients, but rarely will it apply to all. And so a good CPG will have pathways, and there'll be different pathway elements for different patients. Regardless of all of that, if a patient cannot consent voluntarily or withdraw consent voluntarily, we have an ethical problem, a significant ethical problem. My desire is for everyone who comes to hospital to be made well, to have a good recovery, and then ideally go home. But that's not going to be true for everyone. And some people, it won't be true for biomedical reasons. But some people want to make their own choices based on their own belief. And sometimes those beliefs are not that I don't agree with the belief, but it's their belief. So I should respect and accept that my desired framework is this, and everyone fits on this framework. But if a person in a bed says, no, I don't want that intervention, I have no ethical basis really to enforce an intervention on someone. So as hard as it is, every good guideline allows for exceptions.
That patients, they're part of the system if we can embed the guideline into the system. And then all patients, when they come to the hospital, they need to sign for the consent form to receive. And then if guideline is part of the treatment regimen, I think that is, I don't know. So because if it's not for the study, but it's for the guideline, that is a guideline that people are agree and the hospital want to use it as a routine care and embed it in the system, the service system. We ask them at the beginning, right, whether you are going to receive the treatment, the NR or anything, right? So if that guideline is part of the system of the service, it should not be the question anymore. But if in terms of we are going to test it, right, and it is the study, maybe that is an issue that we need to think about. Yeah.
So I'm going to disagree a little bit.
I'm also don't like to disagree as well, because informed consent to receive treatment in the hospital is not the same of informed consent to participate in the research project.
Yeah.
Yeah, that's what I said.
Uh-huh.
If the research project is a big problem, then
Mhm.
we need to ask them and allow them. But if it is like the routine care,
I'm sorry. If it's part of the if it is part of the treatment regimen and saying that, okay, if you admit to this ward A, we are going to do 1, 2, 3, 4, 5, and 1 of 5 is a guideline. And then they sign at the beginning. That is not a problem. But if a research study is a problem because it's not part of the routine care, that's what I mentioned. So you can disagree with me.
I would like to disagree with you a little bit. All right, just a little bit. So in general, yes, people come into hospital and they expect that we have standardized approaches to care. And the best way for a hospital to run is to have maximal number of standardized approaches to care. So actually, just as a curiosity aside from the topic, if we introduce standardized care, even not based on evidence, just based on expertise available, we will improve outcomes for patients more than just allowing variation. So standardization has inherent value and quality to the system. This was studied by a group of European physicians in the 1980s, and it was shown to be true. Reducing variability is really good for health and well-being for people. But here's where I wanted to a little bit disagree with you. Patrapon, allow me to disagree. I feel so honored. I'm glad we're recording this. But here's where I think it gets ethically complicated. So in my hospital, the SOP says for preoperative orthopedic patients that are at high risk of blood loss intraoperatively, if hemoglobin is below X, we transfuse preoperatively as the guideline. But should a patient have a right, so this is SOP, standard care, not research. Should a patient have the right to refuse a blood transfusion? Okay, so consistently, yes, there's routine care, and I agree fully with that. But there are also aspects of care where patient values, beliefs, even just they just might not want it. Like I'm sure, who's, without giving anything personal away, who's been admitted to hospital? Anyone? Just me. Anyone been? You've been in hospital? It's not nice, is it? I mean, we do our best and we love and we care for people, but being in hospitals, the minimum intervention you can have and the faster you get out, the safer you will be with hospitals. So I agree, and also a little bit over to you, Professor.
Can I say something relevant to that? That is yes. And in that case, in these circumstances, if Miss A said that, oh, I don't want even the guideline saying that my hemoglobin is, low standard and I need to have the blood transfer. In that case, the nurse or the doctor need to ask them to sign because they have their own right to sign for NR or not receive the treatment because it's part of the treatment. And yes, every patient have their own right at any time, even they consent us to do anything, right? But at the procedure, at the specific time or a specific event, they still they have their own right, and also the caregiver's right as well, right? So that's why they can say no. Yeah. So I think it's art. Yeah, it's like you said, the science sometimes. So we need to think holistic. Yeah, and sometimes, yeah, in that case, yeah, they can say no. But as a healthcare provider, we need to ask them to sign that they don't want to receive even the guidelines saying that if we don't give you the blood, you are going to have blah blah blah. So they need to say yes, I will, take a risk if I don't go by the standardized care. Yeah, I think that is going to happen.
May I back to my question? Yeah, and this one is my experience working with the student. We do informed consent process and give them the information all, and then whenever they make decision not to join, because it is a standard of care at the period of time, so they still receive the standard care, but we not use their data to analyze. So I don't know, this is maybe one method, but I don't know, maybe more than this one. But what we do, because that one is a good, what should I say? The good, the high, the quality clinical practice guideline. So then that one is approved. So that one is like a standard care at the period of time of data collection. So they still receive care based upon the guideline. As you mentioned that not everybody receive the same thing, right? But follow the recommendation. And eventually when they say no, we're gonna tell them that we not use their data to analyze. That one, I don't know. It just only would like to discuss with you.
And they don't want to get that, you still get it, but you just don't collect the data. You don't follow their willing.
In
Right?
terms of the we give them in terms of this is the standard care of the unit now. So we provide it and we would like to evaluate it. So that one, we it means that we not use that data,
Yeah,
that
only you don't use the
information.
data, but you still give them that.
That one, because
Yeah.
it is the ethical issue that we should get them equally, right? And also in terms of the people should be received equally. I should not say fairness. I should say the fairness and the equity of the care based upon the guideline. Because if you say no, how the staff in the unit taking care of the patient, right? You can say no, I'm not evaluate their falling risk or whatever. But it is only one experience based upon the real situation. And also maybe another one, not now. If the nurse say no, I don't want to follow the guideline, what the researcher should do. That one. Because I'm sorry that I leave exercise before lunch, but only sharing and would like to know about the people perspective, because this one, what did I do? Maybe have the another method. That one maybe in the future that I can
Yeah.
guide the student.
Yeah. Look, the first question is really difficult. It is just really difficult. Fundamentally, people should have the right to reject a treatment offer, whether it's standard or non-standard. A patient should always have the right to reject a treatment offer. And the second question is, what if a nurse doesn't want to use like a standard treatment protocol? And this is really a question that we now look at in terms of implementation science, right? So, in fact, any change, you know, the normal distribution, the standard bell curve, normal distribution. So if you introduce a change, the normal distribution starts off low, early innovators, early adopters, quick to pick up, excited, love it. And then you get up to the middle of the curve and around, and you get delayed uptake by the tail, right? So slow or late. So no intervention, no change is going to be embraced fully 100% at the start. And the question is, what do we do? Or really the question is, how do we help people to come on board? And this is, I think, the philosophy we have to have. Practice change is not a technical process. It's not a knowledge process. And it's not about introducing an intervention. Practice change is about helping people change their beliefs and their behavior. It's a human endeavor. So I can have a great technique that I want to introduce, but the technique is not the change. Human endeavor is the change. So what do I want to do? Some people will do things straight away. You tell them they do it. Not Patrapon, she's her own boss. But some people will follow straight away and they see this is good, this is different, I'm going to do this. Other people have different reasons and they might feel threatened. They might feel vulnerable, or they might feel angry or resentful. Why are you leading this work? I should be leading this work. Lots of complex, because humans are complex. So I want to use behavior change theory to help me, not to make them change, not to coerce change, but to help me understand how to communicate my change plans, my vision, in such a way that enables them to say yes. So I can look at behavior change theory and I can bring some of that in because they've studied the determinants. And you can look at the theoretical domains framework, TDF, theoretical domains framework. It contains determinate behavior descriptors that help you decide what is the barrier that I want to overcome. Is it emotional? Is it cognitive? Is it some other kind of barrier? And then you can do targeted work. And so look at TDF, look at COM-B, capability, opportunity, and motivation, inform behavior. Look at the consolidated, there's many, but only look at one or two, otherwise it's crazy. There's one other thing I would say, and I learnt this from a professor at Oxford University. don't use the word but, use the word and. For example, I hear what you're saying, but, which means I disagree entirely. What if we say, I hear what you're saying, and it's a simple rubric, and engages, but closes. Like, that's not an analogy for anything. This is just simple English language. Use and. I hear what you're saying, and do I have a few more minutes? Oh, 1 minute. Oh, maybe we can talk. Maybe we can talk over lunch or something, because I have a story I want to tell you. And you online, you don't get to hear the story because we have to stop in 1 minute. But thank you for everyone that's been here. I really appreciate it. No, it's good. We need to stop. Busy people, busy lives. I understand. Busy nurses. Yeah. Great questions. Thank you.
Maybe I have a quick question. In your publication, you would also discuss that inter-rater reliability is quite a moderate, right? It means that when we apply in different person, for example, for IRB member to implement that evaluation, they might get different output. Do you think that we can implement it yet, or wait for another investigation for you, because you discussed that you need like more people to evaluate to like evaluate more inter-rater reliability. Yeah.
Also, a wonderful question. The really practical answer is there is no other tool like this in the world. It is currently the best available instrument, so we should use it. Should that instrument improve over time? Yes. If you want to wait, how long do you want to wait for? What rate of reliability score would convince you? And that's a philosophical, don't answer that, right? So eventually there will be a improved number because we will evaluate and pilot continuously. This is ongoing research. But also there's a principle around, philosophic principle here around, we currently do not have something that helps with this. There is an instrument now that helps with this. It's not perfect, but it is helpful. So we could use it. It's a little like, do we wait for a randomized controlled trial, or do we encourage people to stop smoking now? We know smoking is harmful. We believe it's harmful, never been proved by RCT, right? Only by cohort studies, longitudinal, large, but no true randomization. Should we have face masks in public during a pandemic? No good RCTs for the first 3 years of COVID. And all the leading, apart from a small group, most of the leading professors and epidemiologists said wear a face mask right now. Why? Because it could reduce the risk of harm. Not because it had been objectively, empirically proven to reduce the risk of harm specific to COVID-19, but in general from other scenarios. So there's a philosophical and a pragmatic reason for using it now. But also maybe if you're going to use it now, we should collaborate and study at the same time as implement. And you could be part of the study and part of the authorship team as we do further work to improve this. And I would love that partnership. I really would.